my email address. Do you want to send it that?
Yeah, can you let me know your email?
Yeah.
It's for this afternoon, so there's no rush.
Oh, right.
Yeah, the two that are outstanding are for this afternoon.
Mike. Are you on it?
Right, that's your email?
Confess to being an economist, although a somewhat discredited profession these days. But we spend our time talking about clusters, we spend our time talking about the importance of triple helix, and of course what better than celebrating a conference around the triple helix in the helix development here today. I should also start off by saying that I'm the person in the room who probably knows the least about the sector and the cluster. And in fact, my knowledge of technical knowledge is best summed up by the fact that I met my old chemistry tutor who now works at Durham University at a round table recently, and I actually didn't recognise him. So apologies that I've kind of forgotten all the technical understanding and sort of context I might once have had. But what I can do and the role of the Combined Authority is really to amplify the message that comes through from you. We don't really need to understand the science, but what we do need to understand is what your needs are, your requirements are, and how we can best support you on your journey through to success. So I'm just going to canter through a couple of slides. There might be time for a question or two as well, with a bit of luck. Probably not if I don't find the clicker. Here we go. So I am not going to go through these slides in great detail, but what I wanted to say is that Combined Authorities, we've been asked by government to come forward with local growth plans. In fact, that's what we would want to do as a newly established authority as well. And the growth plan provides us with the opportunity to set out the strategic context, the things that are important, how we need to get our ecosystem and our economy working, and to highlight some of the key sectors and initiatives. But it also gives us a chance to, if you like, talk about the narrative, to try and connect what's going on here in the North East with what Whitehall ministers and senior officials are thinking, and to bring opportunity within the region. So getting that narrative is absolutely right. And this is a sort of plan on the page. And I guess what I wanted to highlight is that we are very much aware of the importance of the ecosystem, about getting things like skills, access to finance right, but we're also aware of the need to call out some of our key sectors and clusters. And we fought very hard actually within the North East to make sure that we're recognised as being one of the areas of the country with the most vibrant, exciting life sciences clusters, and to be called out within the sector plans. We were absolutely delighted by, and we've represented that, called that out. We're calling that out within our local growth plan. We're currently going through a process of refreshing our plan. We had it out for consultation. I'm more than happy to take any sort of last minute comments and amendments before we finalise that in November. So just in terms of innovation, so everyone's talking about innovation from a national government perspective, and of course at a regional perspective. It's long been an area of focus and priority. And what we're trying to do on this slide is to, if you like, summarise an approach to innovation within the North East, and recognising the changing world that we're in, and in particular in that changing world, the increasing importance of digitisation. And the announcement that happened a week ago by the Secretary of State around the North East being the first AI growth zone since government published its AI opportunities plan back in January. So real opportunities around digital, and we need to make sure that they stretch from AI all the way through to a much greater swathe of businesses and individuals embracing AI, and of course making sure that every resident has access to digital literacy and opportunities as well. So that adoption and diffusion of technology, but particularly digital technologies, is important going forward. And then of course we need to highlight and to call out those sectoral opportunities that we have within the region, including within life sciences. And we see that as an absolutely core approach. What we need to do in the North East is to really call out those areas of expertise, to shine the spotlight, and to encourage DCIT, Innovate UK and UKRI and others to invest in you. And at the same time, we're trying to provide that ecosystem around it. But from our point of view, what we want to try and do is to exemplify and to make that bridge into those funding streams as easy and comfortable as possible. And then the final strand, which is something that we feel incredibly passionately about, and actually I know is very much aligned to the North East, values and ethos really as a region, is to make sure that, benefits, the economic benefits stretch out to all our communities. And we believe that innovation shouldn't be viewed as being an exclusive activity. We do need to make sure those benefits flow down to our residents and citizens, and we're connecting people to opportunities. And actually going back to the AI Growth Zone announcement, that is absolutely at the forefront of the mind of the Secretary of State when she came to visit, is how can we connect ordinary people with the opportunities that are taking place, often behind closed and often behind locked doors as well, to make sure that the progression through is as easy as possible. Just in terms of the life sciences, so I said I'm the least informed person in the room around the sector, so I'm not going to embarrass myself by trying to describe the sector to back to yourselves. But what I wanted to do is just to say, we have heard, a number of the key features and opportunities. We want to call out businesses. It's quite challenging with a cluster like this where, we could have mentioned 100 or 200 businesses, and we know about the important role that's played by, the universities and healthcare trusts as well. And my view is that all successful clusters need to have a successful cluster body. So, my thanks to Mari and others as well for making this conference proceed, and actually to you all for it being so well attended. In terms of the growth plan, we're also, we also want to highlight those areas of opportunity and differentiation, and to be clear where we have those areas that are important to the regional, but also at a national and international stage. But what I should say, and there's many of my colleagues are here in the room here today, and we want to hear from you as well about what we can do, but also what you can do as well to promote that, and real opportunities ahead for that transformational sort of change in treating chronic diseases. As I've said already, we've got a vibrant cluster, a brilliant business representative.
So, but anyway, if you want to catch Stuart and Alistair, they'll be around at the break. Thank you very much indeed, guys. Okay. So I want to move us on now to another growingly important element of the development of diagnostics, the way in which we are able to use data. The NHS is short of all sorts of things at the moment. One of the things that we are not short of is data. We are, however, short of being able to use it as well and as effectively as we can to deliver improvements in healthcare. So I'm delighted that Pedro and Jonathan are going to come and tell us about that. Where are they? Ah, here they are. There they are. Welcome, guys. Yeah, that's probably easiest. Yeah.
Well, happy to be here. I'm Pedro Ramos. I'm a physician, researcher at a medical university called Karolinska Institute, and the CEO of this company here that is on this logo called Promptly Health. Well, thank you for the team at Newcastle NHS Trust for inviting us to present, especially to Wayne, to Mel, to Vicky. We have been whom we have been working with for the past year. We have been invited so many times in the past year to Newcastle that I'm considering buying some season tickets to St. James Park. No chance. You said that yesterday. No chance. But I still consider that you are rocking in the Champions now. So maybe that's a good. So how should I? How can I move the slides? Like this? Yeah, exactly. So it's always good to start a presentation by something that you don't truly believe. Like this sentence here. Patients are at the heart of the healthcare data universe, right? So if we were able to hand over the data of each patient to his smartphone or to something that he would be able to hold, I think that would be the actual perfect data universe. But the reality is, like was being said before, that the majority of the healthcare data still exists in the hospitals. Hospitals are the big holders of healthcare data, and I think it's fair to say that we in the hospital side always believe that our data is the best. We always say that we are sitting in a big pot of gold. This sentence is something that I've said in the hospital side many times, and we have heard many times from hospitals. But the truth is that when you look under the hood, the reality is that the vast amount of data that is usually in the EMRs, it's actually not activated. So in the majority of the use cases that you would want access to some data for real-world evidence, like the previous panel that was mentioning that they would want to validate their technology, that data is actually not really readily accessible. And it is not by default being improved, being linked, and being checked against like some really basic data quality checks that you would be able to almost do in almost all variables, all clinical variables that you know. And I think it's recognizing, I wouldn't say this problem, but more this opportunity that in the past year we have been working with the Newcastle NHS Trust. In simple terms, what we are doing is we deployed a platform, a technology that we created that is local, is in their system, so it's not in our cloud, it's in their own premise. And what is actually doing is harmonizing this data. We always compare it to creating a library here at Newcastle, where we are like reading all the books. We have an AI agent that is reading all the books, and it's cataloging every page to a specific subject that book actually has. I think that more than the technology, why technology is the last word and not the first, I think what this year has been proving is that really the challenge here is trust. Of course, we are a company, and the hospital is a public organization, and really the big part of this year has been and continues to be and will be on building this trust on the organizations, but also between the people, like having weekly meetings. Like we have weekly meetings to discuss opportunities, to of course monitor on the progress of the project. So really building these trustworthy relationships is the first part for us to start discussing how companies, like technology companies, small technology companies, and I would even say larger life science companies, can actually work together with the public sector. We hope this is a seed that with this trust, we can also, let's say, borrow some trust that the Newcastle NHS Trust already has in the region, for us to then go broader. Like think of, there are other hospitals in the region that could benefit from a broader alliance, a broader use of data across multiple hospitals, link this data, and start thinking of the Northeast as really a powerhouse of the use of data, not only in the UK, but also for Europe, and why not globally. I think, well, this slide, I think it's very obvious. When you are able to activate the data, and again, this depends on trust, then the opportunities are immense. We have been discussing a few of these with Newcastle team. We have several projects on the pipeline, several uses of data on the pipeline. Some are commercial, like will be discussed next, but some are also like public funding, like we discuss European research opportunities that we go together. Again, I think all comes back to like really using that and improving that gold, but having the trust to actually working together side by side. And the benefit for it is also how to improve finance, really use some of those assets to revert funding and revert revenue back to the hospitals. And we have a very clear model where all the uses of data that exist with data on Newcastle are used to then reinvest on the public sector. That can be with typical real world evidence projects that already exist, but but take a more manual route. But it can also be with actually start curating some specific data sets to use for like drug development purposes. And why not? Like the future, of course, is on AI. Like one of the sessions before was this AI growth strategy for the Northeast. There are several opportunities emerging for AI factories in Europe. The term AI factory is really something that is growing in Europe, and of course, in the end, the actual fuel for building AI products is actually good curated data. And I really believe again that with the work that we are doing here in the Northeast with Newcastle, we can be really a node for good data that can be used in a secure, safe way for the benefit of patients, for improving innovation, like with new AI projects. We then, of course, have potential clients that can use this data, and I guess one of the examples that we have been working very closely is Novartis. We have been, fortunately, we and Novartis are strategic partners to, we and Newcastle are strategic partners to Novartis, so we are like finding ways for us to really build this trust and start working in a very trustworthy way. And maybe this opens the floor for you, Jonathan, to explain also your views on this.
Thank you, Pedro. I'm using my phone for my slide notes. I promise I'm not posting on Snapchat or Flapjack, as my daughter likes to call it. So my name is Jonathan. I'm the Medical Affairs Director for Novartis, and part of my role is overseeing real-world evidence generation and integrated evidence plans. So it gives me great pleasure to speak to you today about data partnerships alongside Pedro. Over the next few minutes, I'd like to speak a little bit about the real-world evidence from a pharmaceutical perspective. I'm going to be addressing some of the current challenges we have with data access. I'll then be giving an example of how we've managed to overcome some of those challenges. And then I'd like to conclude with where I see the future of data partnerships to access to optimize patient care. So real-world evidence is relied upon by the pharmaceutical industry to reinforce findings from clinical development programs in a less controlled real-world environment, but it requires access to trusted and reliable data sources. And with a healthcare system like the NHS, work is continually done to assess and evaluate healthcare decision-making and processes. And while these two approaches come at things from a slightly different angle, the goal is the same: to improve patient care and outcomes. And so what we look for are opportunities to collaborate and to work in partnership with healthcare systems, and doing so comes with numerous benefits: increased efficiency, shared resources, and the opportunity to scale, which is particularly valuable in areas such as rare diseases where the populations can be so small. Clearly, any data partnership project will require data sharing and access to external data sources, and at the moment that comes with some significant challenges, and they can potentially really limit the impact of the value of the project. So timelines can be impacted by variable data update schedules, meaning that by the time the data is available, it's often out of date. And access to certain data sources can take a long time to plan and undertake potentially lengthy feasibility assessments. There are often issues with consistency of data structure, format and quality, making it particularly challenging to link data sources, and any work on standardization such as the OMOPS common data model can be hampered by limited uptake. Building on the issue of data quality and consistency, coding inconsistencies and missing or incomplete data are significant factors that can potentially introduce bias into projects. And a lack of shared governance and ambiguities in terms of data ownership can affect contracting and usage rights. Before we even get to any of those points, there's the question of the fitness for purpose and lack of transparency around certain data sources. So what data is available and whether it will address the questions being asked or suit their ultimate use cases, such as regulatory environments. And finally, these projects require oversight of a multidisciplinary team, requiring significant resourcing with shared skills and knowledge. So those are challenges not necessarily unique to any specific disease area or research question, but when you go into certain subjects into more detail, further challenges can be unearthed, such as in the cardiovascular space, where alongside the data capture and the coding issues just mentioned, there are issues with a very fragmented data landscape, in particular in labs and pathology services. So with all these challenges, it's a wonder any data partnerships actually work or will get off the ground, but thankfully they do. And it's thanks in no small part to groups such as Newcastle, where this sort of work is not just supported but encouraged. And in this particular example, there was a shared aim to address evidence gaps and evaluate strategies to improve adoption and standardization of lipid testing, to provide data that contributes to improvements in patient care. This slide provides a schematic of the project with each of the stakeholders in the data network project. So the NHS trusts provide anonymised patient data and worked in partnership with Promptly, the intermediary on data harmonisation. And Pedro touched upon some of the points around data harmonisation there, provided by Promptly, providing a secure data environment, working on the extraction, harmonisation and data analysis. And Novartis acted as the project initiator and sponsor, but also working to address evidence gaps, supporting PPI, so patient and public involvement, and dissemination of findings, and engaging with stakeholders to guide the delivery of the project. And we also had representation from each of those groups in the steering committee to oversee the project delivery, all with the aim of improving patient outcomes. And so to conclude on where I see this go one step further, while we were really pleased to be able to contribute to the data network project to address one stage of a patient journey, and there are many other such examples, where we'd like to get to is a coordinated approach that tracks along the whole patient journey as shown here. We know that multiple data sources are available, and these can be loosely attributed to each stage of a patient journey, from population health screening with tools such as Our Future Health, onto the diagnosis of diseases with CPRD and potentially HES data, secure data environments and disease-specific registries, contributing data around treatment initiation and evaluation, and the audit cycle to continuously evaluate ongoing follow-up. However, to build on this would be to link these secure data sources using a federated model with a single point of entry, transparent and standardized processes and data formats. And as an industry, we welcome the government's proposal for HDRS and look forward to seeing how that will manifest. The potential wins of accelerated research, both in clinical trials and real-world evidence generation, supporting innovation and earlier access to medicines, and these will hopefully allow us to ultimately take a step forward towards optimizing patient care. Thank you very much for your attention.
So, Pedro, Jonathan, thank you very much indeed for that. I think that's just a really good exposition of where we are in terms of the whole issue of how we begin to use the data, the huge amounts of data that we have available to us most effectively to move things forward. I'm aware that I'm now between you and coffee. However, does anybody have any questions they would like to ask either Pedro or Jonathan? Yes.
How do you deal with the concept of data ownership, given that the data that you're working with is the patients? So how do you reassure the patient that their data is safe and secure and actually has permission to use it in the first place?
Pedro, do you want to? I don't mind. Whoever of you would prefer to take that one.
Yeah, so the patients are involved in patient committees for all the projects, and of course the data is de-identified, and even for the outputs, the data is totally anonymized. So it's actually aggregated data. So actually fully anonymized data in the concept of actually de facto anonymization. So the data that stays in Newcastle is de-identified, but the data that is used for the project is only for potential project that was mentioned is only anonymized data.
Okay, so just check with the concept with are those patients given their permission to use that data? Is it correct? Is it collected correctly? Because patients may not know the data has been used in these new processes. How is
yeah.
So Pedro, do you want to comment, and then Wayne, who's sitting right behind you, I think will comment because he's done a lot of work on this.
Yes. So just a brief comment on that. So we are for the actual participation of the patient in the research process, we are using the same framework that the Data Saves Lives is using, that is involving patients in the governance committees for the use of data. So not all the patients that exist in Newcastle, but there are let's say, champion patients that are included in these patient committees, and that is being done across the entire country. But
So
maybe.
Yeah, Wayne, do you want to comment on that?
Yeah, and just to reinforce that, all patients have the opportunity to opt out as well through the national opt-out process. But furthermore, we didn't just rely on that. We've done a lot of public and patient engagement, and we've held sessions in the trust. And we've also, for one project, we've written to all of our patients. So that's 40,000 letters going out, informing them of these great research projects and giving them the opportunity to feed back to us, to tell us how we can improve and do better. And also, if they want to opt out. So we feel as though at every stage they have that choice in terms of being part of this great journey.
So I think this is an absolutely key area for us to get right, because if we don't, then we'll lose the confidence of the public and of our patients. And I think it is essential that we do that. I say that partly from a personal level and partly also because I happen to be the Trust Caldecott Guardian. So if we don't get it right, it's my fault. So I think this is absolutely essential. Yeah.
Thank you. Thank you for the talk. Such a critical area. I hear the word patients, but who are your controls? And how do you define a control population that really enables you to pull the power of a diagnostic set of information towards good therapies?
Well, maybe not going too deep, too fast down the rabbit hole, but depending of course, these are research studies. So each research study has its own methodology. The most common one for these real-world evidence studies is to create synthetic control arms. So you would, in a way, create a control arm that is synthetic with patient matching characteristics. Because these are not clinical trials, right? These are real-world evidence projects in, let's say, phase 4 type of projects. And the most traditional way to do it in clinical data is to use synthetic control arms, where you match the let's say intervention population with a synthetic matched population that has not received the intervention. For projects that are not descriptive, because some part of this project, since the data is actually not accessible, like Novartis was saying, some of the initial aims are just purely descriptive in a way, and one of the advantages is being able to actually bring that descriptive nature faster, because in some ways, some of these initial descriptive nature can take 1 year, and 1 year just to get really treatment journeys and really more high-level descriptive views on the treatment journeys is too lengthy. So yeah, these two dimensions are maybe the right answer to your point.
Okay. One final question from Nick, and then we'll move on to coffee.
Nick Reynolds, I'm a PI of an NIHR data project called AI Multiply, and we've done a lot of work with patients, and I would reinforce that patients really want their data to be used. I think the complexity here may be around the commercial side, and I think that's really important to underscore and to make sure that everyone's aware of that. I think the other important thing which you did emphasize was the join up with primary care, and as you know, the region is working really hard to try and join secondary and primary care together, because it's clear from what we've been doing that people moving in and out of different systems and relying on one data source is not necessarily optimal.
Okay, thank you very much, Nick. Right, I think we should break there for coffee. Thank you very much, Pedro and Jonathan. Thank you. And thank you to all our speakers this morning. I think what we've tried to show you in this first session is the diversity of the work that is going on, and a whole series of different contexts. We'll move on after the break to start thinking very specifically about the 3 shifts in the 10-year plan, and how we're going to address the challenges that those set for us. We've given long breaks in this meeting because the feedback we've had from previous ones is that the bit that people value most, sorry speakers, but the bit that people value most is the opportunity to network. The I love the talks as well. So please take time to talk to people you know, talk to people you've never met before, and we'll see you back in here at 11:45. Thank you very much indeed.
1, 2. That's good. Yep. 1, 2. 2, 2, 2. Check. 1, 2.
To me.
1, 2. 2, 2.
Oh, yeah. Yeah. Yep. Looks good, yeah. Thank you.
One, two, two.
Okay. And then I'll just, I'll help you stand up and say a couple of things before you and Henry comes up, just to close it. So okay.
No, I'll come and see you when we come and sit down. Yeah. I'll just test it now. Jump on you.
One, two. 2, 2, 2. 1, 2, 2. 1, 2.
Yes, fine, no problem. Absolutely fine.
Yeah.
I prefer doing the introduction than the talking times.
Yeah, I know it's better, isn't it? After the cheers here and I think when the lights come on, it's like lights come on. I can't see the faces of anyone.
Oh dear.
That's good.
It's fabulous.
Right, okay. Yeah.
Okay.
So if you find it,
Okay. Yeah. Okay, fabulous. Okay, dokes.
Great.
Are you Kate?
I'm Vicky.
Vicky?
Yes.
Oh, where are you?
So I am chairing this
Ah,
session.
you
Yes.
are, okay. So you're going to use the next one.
Yes, I'm just going to introduce that and I'm just going to come sit back around and
Okay,
just go
super.
between those two.
Super, fine. You can use three.
So Mary's gone to find David and Chris and Kate.
Okay.
Yes. So she should bring them back.
Good, good. Yeah, just when you're using the letter,
Yep.
speak to the people in the front row.
Yeah, okay.
Not to yourself.
Not to myself. Yes.
Don't speak to them.
Okay.
Who's internalising this?
These are the our speakers here. Hi Kate, how are you? Fine, thank you. I think this gentleman's good, thank you.
Oh, okay. You're going to speak, you'll be like, I'll give you the help.
Yeah, I do.
Okay, cool.
These are just my scribbles.
No, your scribbles are good.
You have, but I did spot, actually. Very sensible.
I think it makes sense for us to just stand up here because we're going to mix and match. It's not
Okay.
a kind of linear thing. So
Okay, okay.
we'll probably.
So as soon as I've said, ta-da, I'm jumping back down over to there, so you'll have all the space that you need up here.
We'll just walk up.
Yeah, okay, all right.
My address without pockets. Oh, we should definitely have a meeting about that because I'd love to do that. We have sat on that data and every conference I go to for cancer analysis, someone say, I actually saw this data and I have measured it 3 times. Surprisingly, it's not it. We have to move on from this.
So yeah, we have
Thank you.
computer scientists who are interested in healthcare research in the university, so we can try that out. Yes.
You would just put this just above your top hand.
Is it just on and you'll manage the on this? We don't have to switch our mics on, you'll do all that bit.
No, I've got that here, but I'm just checking.
I thought it was something to break the ice completely after the
Oh, no, don't worry, don't worry. I'll do that for you.
Appreciate it. I don't know whose bottle that is. Is that your is that your bottle? Yes. Stop talking. I think the microphone's on. Mine? No, mine is not.
Mine is just, oh no, mine is. Let's not have a live microphone.
No, it's mine. It's mine. Yeah.
live at the moment, so I'm going to mute you in a second. But when you speak, speak as if you're speaking to the people in the middle rows, not to the microphone.
Rightio. Good morning, everybody. Welcome back. Welcome back to session 2. I hope you enjoyed session 1 and you've had a nice coffee and a chat. My name is Vicky McFarlane-Reid. I'm the Director for Commercial Development and Innovation at Newcastle Hospitals. And ever since joining the Trust from industry, I've been a really strong supporter of everything that Diagnostics North East does. So no surprise that I think this is the most exciting session of the day, because this is all about demonstrating the value of working with industry partners, working together and delivering something that you can't do on your own. So the title of this session is The 3 Shifts of the NHS and Where Will We Be in 2035? We've got 3 fantastic case studies to go through today, each one of them focusing on one of the 3 key shifts. First up, we will have Solventum, who stay in your seats right now, and they will give us a wonderful case study which links to analog to digital. Then we'll have our second with Roche, which follows up on sickness to prevention. And lastly, we'll have a chaired session run by Dr. Ashley Price, looking at from hospital to community. So no further ado now, I would like to introduce my speakers for the Solventum case study. So could I welcome David and Chris and Kate to the stage, please. Thank you.
You hear me well? Great. It's a very nice venue. Thank you, Vicky, for setting the frame. So my name is David Montano. I'm the Portfolio Manager for Clinician Productivity Solutions at Solventum. I'm very excited to be with you today. I have the privilege to be joined on stage by Dr. Kate Musgrave and Dr. Chris Plummer from Newcastle Hospitals to share with you the results of the implementation of a novel digital application that we call Follow-Up Finder for VTE. VTE stands for venous thromboembolism. It's the result of a collaboration that we started with Newcastle Hospitals about 2 or 3 years ago with the purpose of advancing or optimizing the workflow for thrombosis diagnostics management. This is the clicker, I assume. Yeah. Great. We have kind of a busy agenda today. We're not going to go into all the details of what we're going to tell you. It's just the story of our journey from the identification of the challenges and pain points in thrombosis diagnosis workflow, all the way through the implementation of the solution and ultimately the results and the impact that we managed to achieve. But just a quick word about Solventum, because I think it's not a name that you are very familiar with, at least not yet. Solventum is a new company. It's the result of the separation of 3M healthcare business into an independent, standalone company. So we see ourselves as a new organization, but with a very long legacy of innovation in healthcare, with an aspirational mission of enabling better, smarter, safer healthcare to improve lives, and with a set of values that include put people first, advance together, which I think are perfectly embodied in what we are going to show you today. At a glance, more than 70 years of history of innovation in healthcare, more than 7,300 patents issued, more than 20,000 employees all around the world. It's a very diversified organization. We have 3 main business categories. Of course, I don't have the time to go through all the details, but I encourage you to visit our website, to pass by our stand later today, learn about what we're doing, all the exciting things that we're doing in diagnostics that goes beyond these software applications, but also other applications that we would be happy to discuss with you. Without further ado, leave you the stage.
So my name's Kate. I'm a consultant haematologist and the thrombosis lead at Newcastle Trust, and I'm just going to tell you what our problem was. VTE, or blood clots, are a huge public health problem. So what we mean by that are something you might have heard of as deep vein thrombosis, pulmonary embolism. These are things that kill people. And the people that survive have significant long-term morbidity. We're talking pain, swollen limbs. It affects their ability to work, it affects any age, and the treatment is long-term anticoagulation, or what's colloquially known as blood thinners, and they themselves can put restrictions on a person's life, and it's not uncommon for patients to need them long term. What's even more of a problem for me in particular are hospital-associated blood clots. So these are HATs, or blood clots associated with a stay in hospital. And 50 to 60% of all blood clots are due to being in a hospital. So as a hospital consultant, this is something that really worries me. And they are the leading cause of preventable patient death. And it's something that I feel, not just nationally, but internationally, we need to take more seriously. And we've been limited by this because whereas if you look at something like infection control or MRSA, C. diff, things you might have heard of that we can monitor, it's actually very hard to keep an eye on all the blood clots that we see because there's so many of them, and figuring out which of them are associated with a stay in hospital. And the problem we had in Newcastle is there's 900 scans performed every single day that can potentially show a blood clot. And if you ask a human to go through those, whether that's radiology or that's a nurse, that adds a lot of extra time. It doesn't guarantee that you find all of them. And once you've spent all the time doing it, you can't really do anything with that data. And it's basically impossible. So when I started in the thrombosis service, like many hospitals around the country, we were spending nursing time every morning, desperately trying to find all the people that had had a new blood clot. And it just wasn't possible. We were finding as many as we can, and then we just had to stop, and we had to go and actually start treating the patients, which is what we were there for. So when we went to Solventum, we said we have all the data, we have all the information we need, and we are unable to use it. I'll pass on to David.
Thank you. So exactly how did we use that data? What mechanisms did we put in place to address the problem that Kate's team was facing? So Follow Finder is the articulation of several capabilities. In a nutshell, at its core, there's an algorithm of natural language understanding that identifies and surfaces clinically relevant findings from a clinical narrative. So in this particular use case, the clinically relevant findings is verbiage associated with thrombosis, and the narrative is radiology reports. So we automate the process of surfacing those findings. We integrate with the systems within Newcastle hospitals, in both directions, both for getting access to those radiology reports directly from the PACS reporting system and the integration engines that were already available, and to deliver those results back into an environment that the nurses were already used to working in. So that would be the electronic medical record that Newcastle Hospital uses. So these messages will be delivered in a way that they can be picked up by the electronic medical record and actionable upon to create a work list that the nurses can easily follow so that the patients that are in it are sent to the next level of care in a timely fashion. Therefore, creating efficiencies and reducing the risks or patients not being appropriately identified and managed. I would also like to take a minute to talk about the innovation in terms of how we're working together. It's not only about the technology, but also how Newcastle Hospitals and Solventum put together a very interesting model for collaboration to develop this solution. We established a regular touch point so that we constantly get access to feedback from the nurses that are using the system, so that we continuously improve the algorithm, fine-tune it to reduce the risk of having false positives or false negatives result and getting high levels of accuracy that we're gonna go into in a bit. It's also a first of many kinds kind of customized solution. It's the first time that as an organization we deploy this outside of the US. It's the first time that we deploy it in a Cerner Millennium environment, and it's the first time that we deploy it for this particular use case of thrombosis. So there were many hiccups along the way. It required us to work in an environment of trust. The learning curve was definitely steep, and there were many things that we needed to start and restart again and redefine along the way. But fortunately, with Newcastle Hospitals, we found an environment in which we were able to have that freedom to explore, to test different things, and ultimately to deliver what I think are very exciting results.
Oh, thank you very much. I'm Chris Plum, I'm the CCO, so medical lead for digital in Newcastle Hospitals. And my job in some ways is to join up clinicians with problems with potential solutions. And that's what I think we've done here in a really innovative partnership. We have created something that neither of us could have done on our own. And what does it look like? And this is developed in Newcastle by our app support team, Sarah and Stephen and their colleagues. And instead of the thrombosis nurses coming in on a Monday morning and trying to trawl through hundreds of scan reports in packs, they come in and there's a list of 28 and they click here to go to the radiology report, click here to go to the patient treatment, click here to make a note, and click here to collect actionable data. So we are collecting in real time whether this was a thrombosis or not, whether it was a hospital-acquired thrombosis. And that's completely changed the dial in what we can do in terms of feedback to clinicians, and it's completely changed the way the culture around management of venous thromboembolism in the trust. And it's resulted in very significant improvements in what we can do. And I'll hand back to Kate to tell you about them.
So now I get to tell you the good things. So firstly, it works. It works incredibly well. So it's extremely sensitive. And we have various systems in place to check that it's not missing any, and it's brilliant. The number of false positives, we want it to be more sensitive than specific. So there are some false positives, but because of the way it integrates with our e-record, it's very easy to get them off the list. So it works brilliantly. And it's, as Chris said, there's been a real culture shift in how we manage and how we prevent venous thromboembolism. So first of all, compared to how many COTs we were finding before, there's been a 48% increase. Our nurses can spend half an hour now reviewing everyone on the list and giving help when needed. And when we've looked at that, we've realised that a third of our patients are not on the most optimal care for a new blood clot. And the thrombosis team, through our nurse specialists, can reach out and say, you know what, you need that anticoagulant. This person needs to go to vascular, they need a thrombectomy. And things are happening much, much faster. And teams know about us and they're getting referred to our service and they're getting better help later on. One of the things I'm most proud of, though, is we're the first trust that I'm aware of, even internationally, that can in real time say, these are how many hospital-acquired thromboses we have every day. This is how many we have. And we can divide them into saying, okay, we know that as a trust, we are a busy trust, we have a lot of trauma, we have a lot of cancer patients. We can't prevent every blood clot. But what we can say now is, this is the percentage of people that we have done our absolute best to prevent their blood clot. They have had the optimal VT prevention. And anybody where we look at it and we say, this could have been better, it goes straight back to the clinical boards, it's looked at weekly, we report on it quarterly, and instead of having a blame culture of, oh, somebody's had a blood clot, it's, well, actually, what can we do with our system to make this better? How can we reduce it? And so we have cut down the number of people that have suboptimal VT prevention by 53% in 1 year because we have this kind of data and because we have a way of surveilling our system. Also, we freed up 2 hours of nurse specialist time every single day, which is huge and made a massive difference. And they now have regular clinics of their own. They do nurse-led clinics. They're helping patients. They now will see everyone who's had a blood clot in our trust within 3 weeks to check they know exactly what's going on. They understand the blood clot. They understand the treatment. There's no questions. So they're getting that extra support before the medical review later. And I'm really passionate about recruiting to thrombosis clinical trials. They're really hard to recruit to because you need to find somebody with a blood clot and you need to recruit them usually within 5 days if you're lucky, if not shorter. And it's almost impossible, and this is an international problem. So we've got 2 clinical trials running at the moment that internationally aim to get over 1,000 people in the first year and got 83. That's how difficult it is. And this is not an unknown thing. And across the UK, it's a big problem to try and open commercial thrombosis trials. We've increased our finding of eligible people by 100% by using this list. It's an absolute game changer for us.
Now log on to our patient record and automatically we have what is called a VTE list. So in real time, if a patient goes for a scan and is diagnosed with a blood clot, they will automatically add to the list in real time. You don't have to log on to PACS, we don't have the Excel sheet anymore, we all just have everything on e-record, so the patient is there, we can click onto their details straight away, we can add a note straight away from this list that has been made. In fact, it's all in one place. It makes it much more efficient for us. We know about all the blood clots now that are found on scans, and I said the delayed ones are the huge ones for us that aren't missed anymore. So it makes our journey for the patient much easier, their journey, and so much more patient focused in terms of safety.
We decided we couldn't say it better than Robin, so that's great thanks to her. The thrombosis nurses, unfortunately, are looking after people with thrombosis and can't be here today. So just to finish off, why did this has clearly worked for us. Why did it work? What are the key factors to make this work? And I think we're very focused on this because we want to think about what we're going to do next. So we had lots of data. We had lots of high quality scan results, radiology reports, but it was in too big a haystack for the nurses to look through to find the very important time-limited needles there, the patients who would really benefit. And there were quite a lot of those. As Kate has said, 30%, we've actually changed management of those people. We also knew what to do. We had an intervention that was going to change patient outcomes, changing their anticoagulation, putting them on anticoagulation when they weren't on it before. And we had a highly motivated clinical workforce who wanted to make that happen. They just couldn't see the wood for the trees. And then we've derived analytics from it that's changed the culture, changed the dial absolutely within our trust in terms of managing venous thromboembolism. So what's our vision? How does this work for us going forward? For us, I think personally and professionally, it's been a great collaboration between the problem and the problem solver. And I think we've got great plans for taking that forwards. For me, absolutely aligns with the shift from analog to digital. We've got a mass of data, unstructured data, we just can't get actionable insights from, and that's where AI, I think even the AI that we have now in clinical practice absolutely can help us get that actionable information. And what we're doing now, what other problems do we have that fit those success criteria? Where do we go next with this? Because firstly, we're not the only hospital in the world with a VTE problem, but there are lots of other problems where there's too much data for the clinicians to work through quickly enough and efficiently enough to get the best patient outcomes. So we'll stop there and we're happy to answer questions. Thank you very much.
So because the guys did their presentation perfectly to time, they have 5 minutes for questions.
Brilliant, no questions.
Is there a way for the system to do the next step, which is to integrate with electronic health records and look at things like EGFR and drug interactions and things to then subsequently guide clinical management, not to take away anything from the thrombosis nurses, but actually something to help the clinicians to help with management?
Yes. And I think that there's a huge opportunity for EPRs doing more than they do at the moment, which is just hoovering up data. What it needs to do, and everybody knows this, is to aggregate that data and give us back insights. The regulatory requirements around that are absolutely huge, entirely appropriately, so that's a work in progress. This is how do we solve the clear and present danger, if you like, of having the data but not being able to access it fast enough, efficiently enough to get the patient outcomes. So I appreciate we're solving a little bit of the big jigsaw, but it's a really important bit.
Thanks, guys. What a fabulous presentation and a great example of the controlled use of AI. Just brilliant. Very often we see clever tools for little specific problems. This is not a small specific problem. This is something that's a big issue across the globe, actually. But what's the diffusion plan for England? How are we going to get this out there?
We're working on that. We're working on that collaborative model that I was talking about is going to extend to see how we can work together between both organizations to scale this out. I shouldn't say too much about that, but there's gonna be news to come on that front.
But it'd be fair to say that Kate's had some inquiries from friends. Would that be fair to say?
Yes, many clotty friends are very interested.
Hi, thanks. It's a really interesting talk. I just wondered about how you set up the collaboration, because that can't be easy with an NHS group. So how did you find Solventum, and how easy was it to make that happen?
So maybe if I'll comment first, and then David can correct me. So we had a relationship with Solventum around voice recognition, our front-end voice recognition system, and they came to us with a proposition to say, we've got all these other tools. What do you think? Can we work together on some of them? And this is the one that we chose, and Kate's was the project that we chose first because of all the success factors that we've just gone through, and it's really worked. So we're keen to do it again and more, and allow this technology to work for other NHS organisations and more broadly, but also think, what other problems, what other haystacks do we have that we can fix with this kind of solution?
That's brilliant, thank you.
Okay, just thank Chris and Katie and David. Thank you very much.
Thank you.
Okay, great. That was absolutely fantastic. So now we're moving on to our second case study. And this case study focuses on the